We keep hearing about this, right, in the news more often than not. So I have a 30-year-old with a heart attack. I have a 45-year-old who had a bypass, whatnot, sudden cardiac death in late 30s, 40s. Unfortunate irony is that typically South Asians are at higher risk for heart disease. Looking at the data, you will notice that we have heart attacks typically 10 years before the Western population. The problem really is this: we don't have great drugs for treating this. Now, of course, drugs like inclisiran, etc., can drop it by 20 to 25%, which will decrease your risk. But again, we don't have. You can really aggressively control all the other risk factors. Right? If your LP small a is high, treat your cholesterol super well. If you're a pre-diabetic, become a non-diabetic. Lose weight, eat right. Do all the things that you can do so that your overall risk decreases. One thing that I've noticed in India is I keep asking people this. They show up with a heart attack and then I'm like, do you have any medical problems? The answer is no, I'm healthy. You check their HbA1c, you check this. They'd be like, HbA1c is 13. I'd ask the next question. So when do you have a regular doctor? Do you have a primary care doctor? The answer is no, I'm fine. I don't see doctors.
Cholesterol is one of the most important pieces of the puzzle. Understanding it better can help us protect and improve our heart health. Joining us for this session is Dr. Arun Kalyanasundaram, a US board certified interventional cardiologist known for his work in advanced heart care. He serves as director at Promed Hospital, Chennai, and also leads the CTO program at Marshfield Clinic in the United States. Over the years, he has performed more than 2,500 advanced heart procedures and has helped bring several new techniques and innovations to India. Beyond patient care, he is a passionate teacher and mentor who has trained over 250 cardiologists and contributed to international guidelines and training programs. He is also the founder of CHIP CTO India and the Asia Interventional Complications course, and has authored more than 50 scientific publications. With his vast experience in cardiovascular medicine, he continues to shape the future of heart care both in India and around the world. Ladies and gentlemen, please join me in warmly welcoming Dr. Arun Kalyanasundaram onto the stage. Give it up, everybody.
Good morning, everyone. It's truly an honor and a privilege to be talking to so many physicians and a lot of esteemed other guests, so I really appreciate the opportunity. So I'm an interventional cardiologist, and we're going to talk a little bit, do a little bit more of a deep dive into cholesterol and what is some of the cutting edge stuff, right? My disclaimer is that I typically work in the cath lab day in and day out, right? That's kind of my thing. I also wear a different hat, which is you have to try and prevent problems from happening in the first place. So while we can open up really, really difficult blockages, the goal is to see how can I mitigate risk, how can I ensure that people don't get into trouble in the first place. We keep hearing about this, right, in the news more often than not. So I have a 30-year-old with a heart attack. I have a 45-year-old who had a bypass and whatnot, sudden cardiac death in late 30s, 40s. And we see this in the news more often than we should. And again, a lot of the guidelines that we have presently is based on Western data, right? I mean, I practice in two continents primarily, but a lot of our Indian guidelines too are typically, if we ask about, hey, what is our LDL goal? What is this? What is that? We still quote Western studies. We don't have a lot of data for ourselves. And the unfortunate irony is that typically South Asians are at higher risk for heart disease. So looking at the data, you will notice that we have heart attacks typically 10 years before the Western population, right? So, which is why it is not so uncommon. When I first moved back, I used to be shocked anytime I heard, oh my God, there's a 35-year-old with a heart attack. Now I don't even bat an eyelid. I just, okay, it is business as usual. The second thing is that we are at a much higher risk for heart disease. It's not just earlier, it's also a higher risk. And this is also, if you think about it, even the Indians that have immigrated to the US or UK, Australia, wherever, we still are at a higher risk, okay? And one of the things that I think a lot of physicians, I'm sure, are aware is that the lipoprotein small a, it's about 25%. We have elevated lipoprotein small a. This is not typically something that we even check according to the Western guidelines yet. Just recently they've updated, say, hey, check it once in your lifetime. Disproportionately, like, even Dr. Joy Varghese was kind of talking about it, a lot of deaths are due to heart disease globally and in India. Again, few things that I want to bring to your attention. There's this theory called the thrifty gene, thrifty biology, etc. So we come from famine, and our bodies are designed to store stuff, store fat, etc., etc. So which means that now in a world of plenty, where we have access to, some of the things that were mentioned, right? Your high fructose, this, that, everything is pretty much processed. When we consume so many quote unquote junk calories, we end up storing a lot around our abdominal organs. The visceral adiposity is a killer. The BMI again, there are lots of metrics for what is considered an ideal body mass index, body round index. There's a lot of stuff, but without getting into details, the bottom line is for Indians, South Asians, the bar is set higher. So for us, for example, your BMI should be less than 23. For the average Caucasian, African American, whatever else, it's 25. So that's something that's important, right? And again, it's not just the LDL, which I'm sure if it's mostly physicians here, you guys know, LDL is the bad cholesterol, and HDL is the good cholesterol. Typically, we very simplistically, we say non-HDL, non-good cholesterol is all bad. But then the devil's in the details, right? So, what is the particle size, et cetera, et cetera. So you can do a lot of deep dive into this. I've already touched upon LP small a. And the other big irony, and since we have a lot of physicians, I do want to emphasize anyone with heart disease, they should at least be on moderate, if not ideally high dose statins. Statins are cheap. There is a lot of concerns, myths, worries about, if I take statins, I'm not going to do this. If you go on Reddit and do a quick search, you will find every side effect known to man that's been attributed to statins, right? But they have been studied for decades. Yes, they can cause myopathy, they can cause myalgias, they can cause liver dysfunction, and a couple of other side effects. But for people with heart disease, their benefit far outweighs the risk. So potent statin, high intensity should be non-negotiable. What else do we look at beyond cholesterol, right? And a few other things, and I'm kind of crossing boundaries here, but it's important because this affects the heart. It's, if you talk to interventional cardiologists, we are really dumb people. We just like to fix blockages and see, okay, take care, bye-bye, see your general medicine doctor. But the key thing is that we can't live in isolation, right? I can't fix the heart and say, you die because of some other reason. So we have to manage all the things that get them into trouble in the first place. So the buzzword, and this has been the buzzword for, I would say, well more than 2 decades, is inflammation, right? For a lot of people, my very, very first, when I was learning pathology, etc., it used to be that it's a cholesterol problem, it's a lipid problem. Then the buzzword for the last 20 years has been it's an inflammation problem. So there are ways to measure it. You have interleukins, you have hs-CRP, etc. So these can, again, go up for a lot of reasons, but typically, let us say you're not having an infection, there's no other thing that is inflammatory in you. A baseline test is, again, super helpful in terms of risk stratification. The other big thing is insulin resistance. Now, the pendulum has kind of swung towards manage your sugars better, right? So insulin resistance leads to endothelial dysfunction, and a poor endothelial function contributes to more atherosclerosis, more likelihood of plaque rupture, etc. And of course, we've talked about LP small a. And this is not really something that is new, but it's been there. We know about this, but the problem really is this. We don't have great drugs for treating this. Now, of course, drugs like inclisiran, etc., can drop it by 20 to 25%, which will decrease your risk. But again, we don't have great data, right? The important point is that right now, today, as of 2026, what you can do is the reason to measure this is because although you can't fix it, because it's predominantly genetically determined, you can really aggressively control all the other risk factors. So what do I mean by this, right? If your LP small a is high, treat your cholesterol super well. If you're a pre-diabetic, become a non-diabetic. Lose weight, eat right, do all the things that you can do so that your overall risk decreases. It's just like one of those warning things. It's like, well, I can't do much about it, so why check? You check because you know that I'm more likely to have a problem, so I better clean my act, right? And so what do we have today? We have, so again, the last few years has been pretty exciting if you look at it. So number one is, of course, the good old statins. You also have ezetimibe or Zetia that's been around for a while. Now, of course, you now have a few other PCSK9 inhibitors. You have Repatha, you have inclisiran. So anytime someone can't tolerate statins for whatever reason, inclisiran is available. It's 0, 3 months, 6 months, every 6 months. So this is a drug that is an injectable that can be used to reduce your LDL significantly, and it drops numbers I've seen people in single digits of LDL. There's also a concern, I know this is off topic, but there's a big concern that, oh my God, my LDL is 20. Is it too low? Am I going to have a hemorrhagic stroke? These have never been shown in any trial that you're going to have a higher risk of a hemorrhagic stroke because your LDL is too low. I mean, it was a theoretical concern, great theory, but again, not being proven in real life data or in any randomized trial. Of course, the other super exciting things that has happened for us, and cardiologists tend to do this, we cannibalize from other specialties. Angiography was actually started off by radiologists, and then we said, all right, yeah, we'll take it. So coronary angiography became ours. Ultrasound of the heart, echocardiogram, we essentially hijacked. Vascular, we go into every territory and try and then of course the cardiac surgeons are not happy because now we're doing the structural stuff. We tend to do that, and I think medications is also not an exception. So DAPA, EMPA all came up for other indications, but then we also found that this is great for cutting down heart failure hospitalization, both for preserved EF as well as for HFpEF, which is like when you have normal ejection fraction, that is the contractility of the heart is normal. For low EF2, these are super helpful. So across the spectrum, great. And of course, I'm sure you guys everyone knows, right, about your Mounjaro and Wegovy and whatnot. So semaglutide, tirzepatide are again great drugs, and they also have benefits in the cardiovascular arena beyond weight loss, because they help in the metabolic milieu, improving that, your inflammation, your vascular lining. So they have some what we call the pleiotropic effects, the non-traditional effects that are there for that. And this is interesting. And in fact, I started just using this a little bit more. Colchicine is one of those drugs that can cause diarrhea. We typically in cardiology use it when someone has had pericarditis. There's inflammation of the lining surrounding the heart, and they have recurrent pericarditis. Colchicine 0.6 twice a day is recommended for reducing the chance of this happening. But we knew in the back of our mind that this can reduce inflammation, which is why you do it for an inflammatory disease like pericarditis. But then now we also know that there is some data that's emerging that this good old drug can actually help reduce inflammation and thereby your risk of heart disease down the line. And the other drug I think that's worth mentioning is bempedoic acid. Okay, so this is typically again for the non-statin, like if you're intolerant to statin. And again, I'm sure there'll be questions about, do you use inclisiran, bempedoic acid, or statins? I would say your first line, I'm going to preemptively answer this. Your first line should be statins, right? Because it has the most data. Again, it doesn't mean we mix it in the water and everyone drinks that statin, laced water. You don't do that. But for the right patients, I think the benefits far outweighs the risks. And I think as doctors, we always say that every medicine other than lifestyle has a potential side effect, right? So when do you prescribe something? When I think that the potential benefit for that patient outweighs the potential risk. This is true for procedures, this is true for medications. And I tell people this all the time, the only thing that you can do free is, control your stress, walk, no side effects, eat less or eat healthy, etc., etc. And yeah, I mean, I kind of talked about semaglutide, and I think this is great because, you have early benefit, and I already kind of touched upon this, that your weight loss doesn't fully explain. I mean, of course, if you have a lower lower body mass, you're going to have better cardiovascular outcomes. But I think over and beyond that, semaglutide showed kind of that, yeah, this is probably good. And again, we've talked about this too. So, they also work really well for preserved heart function. For those with low heart function, I would be a little bit wary of prescribing this just for cardiovascular benefits, unless you're prescribing it for obesity. And so what's in the pipeline? Lots of exciting stuff, right? So some of the drugs that are out there, I mean, actually none of them are available yet. As you can see, some of them are phase 3. There have been some studies that have come out. But the bottom line is that maybe, just maybe, LP small a is, there are drugs that can drop it big time. Up to, I think, 94% was what was shown in lepodisiran. And these drugs, if it pans out in further trials, I think are very promising, because we were like, hey man, I can't do much about it, so it is what it is. So if we can kind of once these are out there, once there's more data, I think these drugs are very promising and exciting. CETP, if you look at obicetrapib, right? CETP inhibitors got some bad press. The last ones that came out didn't really pan out to be very helpful, but now we know that this new drug actually has shown to reduce LDL. There's some reduction in LPA, it's almost like 40%. So this is good. Then you have the triple drug, which is your retatrutide. So again, a lot of these are, I think, maybe in 2 years from now or whatever, when we have this talk, we can kind of say, hey, here's the data. You guys should be prescribing some of these drugs if you aren't considering already. So, but this is just stay posted. Bempedoic acid is available. Do it for the right reasons. It's available in India. And of course, your anti-inflammatory drugs, like the anti-IL-6 drugs, also are fairly promising. I would say, this is a slide maybe, I don't know if you're going to share the slides, but you could take a picture of this if you want. So already some of it was touched upon by Dr. Joy Verghese. So, hey, you should be looking at fatty liver. Why do we care? Because that's a heart disease predictor, right? You should measure inflammation with HSCRP. There are lots of tests that you can do for your lipids, right? Make sure that you're not insulin resistant. There's a lot of stuff that can be done. And I think unless you measure stuff, you're not going to be able to correct it. You only can fix stuff that you know. If you have numbers, it's actually good. It gives you a good metric. Again, a lot of this is cutting edge. If you do a deep dive and say, okay, do we have 10 randomized trials supporting everything that I've just talked about? Probably not. But again, lack of evidence doesn't mean it doesn't work. It just means you got to be patient. And a lot of this, I'm saying, what we do right now, there's some stuff that we can change our practice because there's good data. There's a lot of new stuff that's coming out that's also pretty interesting. Epicardial fat, gosh, from my fellowship days has been a very big area of interest, because that, again, it goes along with the whole metabolic, or rather your internal organs, your visceral fat. There's a strong correlation. Cutting these, and these are not just markers. The thing is, they're actually bioactive, so that actually promotes your inflammation. It does a lot of bad stuff to you. So we should kind of rethink how we risk assess people. And again, we're talking about a lot of high-tech stuff. I got a couple more minutes, so I'll just give you my 2 cents. One thing that I've noticed in India is I keep asking people this. They show up with a heart attack, and then I'm like, oh, do you have any medical problems? The answer is, no, I'm healthy. And initially I'd be like, wow, that's interesting. And then you do, of course, you check their HbA1c, you check this. They'd be like, HbA1c is 13. And then I got smarter. I'd ask the next question. So when do you have a regular doctor? Do you have a primary care doctor? The answer is, no, I'm fine. I don't see doctors. I'm like, okay, have you had any blood work? Oh yeah, I checked it. The numbers look in the normal range, so I just chose to ignore. This is for the IT staff that's fairly intelligent. There is a very big trust deficit in our ecosystem, and I think that needs to change. The onus is on us to ensure that, hey, people should be seeing general medicine doctors. Ensure that you dot your I's, cross your T's before all the fancy stuff, and only then I think we can be more responsible providers. So yeah, it's not just about plumbing, although I'd like to think so. We can open up blockages, but that should be just for those people that that have failed. It's those people that have had accidents. So I had a couple of nice slides about showing a car wreck and then saying okay, we can fix the car. So what we do is like the body shop thing, your body shops and your mechanics to fix the car because you're doing a better job preventing it in the first place, and that is risk-free. Thank you.
Thank you so much. It was highly informative and engaging. Everybody give it up, please. Thank you, Doctor. And we request Dr. Joy Varghese to kindly join us on stage and do the honors. Please, sir.